morning, everybody. Hope you're all good. Welcome back to Monday. Yeah, it does. I was thinking that. I was like, God, it doesn't seem long since I did the last one, and that's because it wasn't. Nice to be back on a Monday morning. Get a normal kind of routine. It was a bit weird, break of the routine. Morning, Tris. Good to see you there, mate. Cool. Right. So Wednesday was the last one we did, and morning, Claire. Hi, Claire. Good morning. Yeah. So Wednesday was the last one we did, and we looked at the glutes, and then started to go into the inner thigh. And yeah, so we're going to carry on with that today, and then we're going to bring in some of the anterior thigh muscles as well, and the classic psoas debate that there always is about palpation of the psoas. So yeah, we're gonna do that. And hello, Facebook user. If you are on Facebook, then you need to go to this website. If your name is coming up like that, then it's because you haven't let Ecamm use your picture and your name from Facebook. So yeah, if you go to that website, and then it should then automatically update everything. If you can't do that, no worries. It's not a problem. You can remain anonymous, no problems. Right, let's get going then. So this is where we were last time. Yeah. So I'll just skip back a few slides actually, just so what we did. So obviously we covered all of this on Wednesday. So we looked at the posterior thigh Wednesday. Gluteus maximus, so the big muscle at the back. We went from, because we did all the smaller muscles around the hip socket, the hip joint, in a previous session a few weeks ago, and I labelled it the rotator cuff of the hip. So yeah, if you want to have a look at that one, that goes into all of the 6 little muscles around the hip joint. So the gemelli muscles, what else did we look at? The piriformis, quadratus femoris, and there was 2 others as well. I can't remember. But yeah, glute. Then now we're starting to look out a little bit. So the big muscles that provide a lot of the force through the hip, and gluteus maximus was the one of them. And some of the key points were things like this. So the attachment points on the iliac crest. So if someone's coming in complaining of lateral hip pain, lateral pelvis pain, then if it's posterior, then there may be tendinopathy on the attachment on the glute max. But if it's more anterior, then it's very unlikely because it doesn't attach there, and but these ones do. So gluteus medius and gluteus minimus do. Medius a little bit higher than minimus, and these can be really, really sore, really achy. And we're going to talk a little bit about tendinopathy once we've done all the muscles, because looking at pathology of the muscles, it's really the main things are muscle tears and tendinopathies, especially in this region. Some of the other stuff we discussed as well around the hip was that a greater trochanteric problem was often called a bursitis. So if you, and not being disrespectful to GPs, but usually if you went to a GP and you had pain on the outside of your of the pelvis, then you would it would be a bursitis. But the likelihood of it being a bursitis is quite low unless you've had a fall. It's usually an impact, sometimes like a friction irritation, but usually an impact, and much more likely to be some kind of tendinopathy. But when we looked at the attachments of all the muscles into here, as well as all the 6 little rotator cuff muscles as well, then yeah, it's really hard to pinpoint one specific structure. So if it's something around the greater trochanter region, we call that now a GTPS, so a greater trochanteric pain syndrome, because of all the attachment points in there and it being impossible to pin it to one thing. And then piriformis syndrome, so something a little bit further round the back, so a little bit more posterior, a bit deeper. Rather than being a piriformis syndrome now, because again, there are so many structures in that area. In the literature, if you're searching for that kind of thing, it will be a deep gluteal syndrome. Okay, so it's a lot broader, which I think is a better thing, because people got, well, if you Google it, if you Google piriformis syndrome, there's loads of YouTube videos telling you how to fix it, but it may not be your piriformis that's the problem, basically, and we can't tell. Good question there. Oh, hi, Carol. Good to see you in this morning. And yeah, Martin, does max overlap medius? It will do to a certain extent. Yeah, so you'll get some crossover, and underneath sort of the muscle belly area as well, definitely. Attachment wise, yeah, possibly they kind of merge, to be honest, in layers. You pull back one and it'll be attached to the other. And that's a good question. Right, cool. So that's where we were last Wednesday. We also looked at the TFL, the tensor fasciae lata, and how it connects to the iliotibial band, and the fact that the band is not a band, it's fascia that surrounds the whole thigh. So yeah, there was that that we looked at as well. So if you want to have a look at that and see the structure of the IT band, then that was done last Wednesday on the last session, 160. Yeah, 160. Yay! Good morning. Good morning. Grab your coffee. Right, let's go. So yeah, we looked at TFL, and then we briefly looked, which is what I'll recap today, at the first of the adductors. So I came up. This is how I used to remember the adductors. It's at 10 o'clock, maybe not a great time when the recycling's being collected. I don't know whether you can hear that. So we've got 3 ducks pecking grass, or grass, depends where you're from. So the 3 ducks are your adductor magnus, brevis, and longus. Okay, magnus means like massive, brevis means small, and longus means long. Okay, so that those names will give away the kind of shape of those muscles. Peckin is pectineus, so a small little muscle, which we'll have a look at in a sec. And then grass is gracilis, which again is another one of your adductor muscles. So these are muscles that bring the thigh towards the midline, so bring it in, and they are predominantly innervated by this nerve. So we've got the obturator nerve. Obturator means to close, and interestingly, with the magnus, it's got a dual nerve supply, and the because it's got dual function. Okay, but the ones that purely adduct, they are innervated by the obturator nerve. Okay, so obturator means to close. And if you remember back when we were looking at the structure of the pelvis, there was a little hole in the pelvis at the bottom where the ischial tuberosities are, called the obturator foramen. So it's an obturator hole, and that's where the obturator stuff goes through. Okay, so again, we'll look at that in when we get to the nerves and the blood supply. Cool. So this is where we finished last time. So we were looking at this muscle here, the adductor magnus, and it's kind of split into 2 parts. There's fibers that travel in a kind of medial, lateral, oblique direction, and there are some that are more inferior, superior direction. And it's because it's got 2 actions. So it's got adduction of the hip, but it will also, well, let's say two. It's got two main actions, and one of its other main actions, it'll be a weak hip flexor because of the attachment points. But the other thing that it's good at is extension. So it's considered to be your fifth hamstring, or it's sometimes that it's mentioned in the same breath as the hamstrings. And it's because of the fibers that go up and down, they help to extend the hip. Okay, so similar to your hamstring muscles, although it attaches onto the femur rather than below onto the tibia. Okay, so we've got two nerve innervations, and they go into the different fibers. So the more horizontal oblique fibers, that's supplied by the obturator nerve, and then the up and down fibers, inferior superior ones, those are the innervated by the sciatic nerve. Okay, so it's got a dual nerve supply for two purposes. So let's have a look at these. Let's get Magnus on there. Hopefully, get rid of that one. Hopefully, this should be adductor Magnus. It's looking good. Yeah, perfect. So just get rid of that as well. There we go. Okay, cool. So we've got, there's also the adductor hiatus, which is really cool. We looked at that during the knee. So that's where the blood supply goes from anterior to posterior around the knee. But look, these are the fiber directions that I was talking about. So hopefully you can see these quite clearly, actually. I'll just pause that there. So see, it's kind of split. So we've got attachments up here around the pubic region. So inferior pubic ramus. A ramus means a branch. So we've got the inferior pubic ramus. So the inferior branch of the pubis. Okay, that's basically what that means. Also the ramus of the ischium. So the ischial branch. Okay, and then the ischial tuberosity, which is the main kind of bony bit on the ischium. So that's the attachment there. So quite a broad attachment. And then look, it fans this way. So that's those kind of more oblique horizontal fibers. And then also it comes up and down here and then attaches via a long tendon there. And then this hiatus area here, the blood supply for your lower limb will lie on this muscle. It will lie on adductor magnus, and then it will go through that hole, pop through into the back of the knee. Okay, and again, like I said, we covered that in the blood supply of the knee. So you can have a look at that there. We'll look in the next couple of weeks where it comes from up here. So so those are the two different fiber directions and the two different nerve supplies coming from those, okay, or innervating those. Cool. So that's what we did Wednesday. Now we're going to add on some other muscles as well. We're going to do brevis and longus together. Just because that's the way the video is, so we'll cover the next two. No worries, Becky. No problem at all. We know what that's like. Okay, so we've got adductor brevis, which means the short adductor. Okay, so that's this one just here. It comes from the body and inferior ramus of the pubis. So again, the inferior branch of the pubic bone. Okay, so there's your tubercle there, and you've got this part of the bone that comes down, so that's the inferior branch. Okay, what does it do? It adducts the hip, so it's a pure adductor, and it's a very, very short, powerful muscle. Okay, again, the adductors are innervated by the obturator nerve, the nerve to close. Okay, so that's the same nerve supply as those oblique fibers of the magnus. And then we've got longus, which is a little bit longer, so it attaches a little bit lower. And we've got the middle third of the linea aspera. And again, you may remember that for when we were looking at the knee and the attachments of the vastus muscles and the short-headed biceps. So the linea aspera means white line. And there's a line, a ridge on the back of the femur, which we'll have a look at in a sec. So obviously you can't see it on this picture. Tucked around the back, there's a raised ridge where this muscle will attach onto. Okay, and again, obturator nerve for this one. Okay, so let's have a look at the video of that one, which hopefully is this. Okay, so longus and brevis. Just pause that. That went really quick. Okay, get ready. Blink and you miss it. Okay, so I'll just pause that there. So we've got longus and brevis, and those are your what you call it, tables for the origins, insertions, and actions. And again, I think it was on Wednesday, maybe the last Monday we did as well, where I was saying that we don't really use origin and insertion anymore. We just use the word attachment point or attachments, because it just gets a bit confusing with origin insertions. I remember that with like fitness exams. What's the insertion of this muscle? And then they put the origin on there as well, and it was just like really annoying to catch people out. So yeah, attachments now, that's what anatomists will use. So here's your adductor magnus. So this is what we were looking at previously, the last muscle. So we've got those oblique fibers this way, and then the vertical fibers this way. Longus means long, brevis means short. Okay, so that's where we're at, and then boom, there we go. So they're added on there. Like I said, blink and you'll miss it. So here's the adductor brevis, okay, and it's laying on top of, so if you think about the layers of those muscles, it's laying on top of that adductor magnus, okay, so that you can make that, well, hopefully be able to make that out in the video. So there's brevis, just there, and there's longus. I'm just going to pull, just go back, it's had there, perfect. So you can see the there's like a fascial divide between the two, and so you've got the brevis above and then the longus below, and the longus I mean, they're going to be this way anyway, where they start in a like a very narrow point and then fan out a little bit, and it's, I mean, there's not much available space up here, so they wouldn't be fanned out the other way. But also it helps with the direction of force and then the generation of force in that adduction movement. Okay, so the shape of the muscles helps with that. So we've got, yeah, adductor brevis just above, longus just below, and you can see where they overlap. But longus doesn't go over that hiatus. Okay, amazing design basically for that, isn't it? So we've got that point just there where even that muscle there doesn't cover the top part of that hole. Cool, right, let's have a look at the rest of this. So that, yeah, there's longus. So these are your attachment points on the pubis. So longus attachment and then brevis attachment just there. So that this could, and there's your linea aspera. Okay, that this white line on the back just there. In fact, that was a wee bit too quick. Let's just go back a second. Yeah, so there's your attachment points here. Okay, pubic bone, and then so they're right close to the pubic bone. So sometimes this can be confused with like a herniation. Okay, and these muscles are often involved in what's called a sportsman's hernia. Okay, so it's like a pull on the insertion point. So in like tendinopathy type terms, it's an enthesopathy. Right, sorry for the long words, but it's that the enthesis is where the muscle turns into a tendon and then the tendon attaches into the bone. So you can have a pull around here in that pubic region just there. So that can be an issue. And then if we come round the back, so just there, so there's your magnus attachment, there's the brevis attachment. So they kind of overlap each other, and then the longus attachment is a little bit lower just here. Okay, so they're coming round to the back of the femur, and very close to the attachment points for like vastus lateralis. Okay, and your short head of biceps femoris as well. Okay, so loads and loads of attachment points here. So sometimes, again, people can like feel symptoms on the back of their thigh and will think it's a hamstring, but it could also be adductors because of the attachments there. So we've got common areas where you'll get tendinopathies, but you can get them in any muscle. So if they've had a particular, if they play a particular sport, especially that involves a lot of lateral movement, then it wouldn't be a surprise if these were causing some problems as well. So that's your attachment points there. And then here they are again. So they're overlaying there. Longus stops just above that hiatus. Yeah. Cool. So that's longus and brevis. So those are your three ducts. Yeah. So we had adductor magnus, adductor longus, adductor brevis, your three ducts. Then we have a look at pectineus. So pectin. And if you have a look here, this is a slightly different area to your longus and brevis. So if you are skilled, I mean, you've got to be skilled in palpation in this area anyway, but pectineus is usually one of the ones that is affected in groin strains. Okay, so it's quite common that this is an issue. We've got a dual nerve supply again, because this one, because of the angle of it, it's involved a little bit more in flexion because of the position of the attachment points. Okay, but also adduction as well. So we've got dual function, so dual nerve supply. So we've got femoral nerve and then the obturator nerve. And again, we'll look at those as we go through. So that's your pectineus. And then the next one, pectin, and then this one is gras. So this is gracilis. This is a pure, well, I said pure. It's because of its attachment, it is a weak flexor and a weak medial rotator, but it is mainly an adductor. Okay, so it mainly adducts the hip. And that makes sense if you look at the line that it follows. Yeah, so if that muscle contracts, yes, you will get an element of flexion and medial rotation, but it's mainly adduction that gracilis does. There's a neat little trick for this with exercises. So if you want to work the short adductors, so pectineus, longus, brevis, and magnus, even though I say short, but the ones that don't go below the knee. Gracilis obviously goes below the knee. Okay, so if you're wanting to challenge those shorter adductor muscles, then you can do what's called a Copenhagen exercise, where you do like an inner thigh side plank. Okay, if you Google Copenhagen, you'll find it. But there's the point at which you take your body weight should be above the knee. Okay, because if you want to focus on those, if you have your foot on the bench or whatever it is as you're doing that exercise, you will also bring in gracilis. Okay, so it depends whether you want to or not. Sometimes you want to challenge these closer hip muscles a little bit more, adductors. Sometimes you want to challenge gracilis as well. Okay, so it's up to you. You could do either or you could do both. But yeah, you're going to bias the shorter ones if the knee is the point of contact on the bench. Okay, right. Let's have a look at these. So pectineus and gracilis. Okay, so this is where we were before with your adductor magnus, and then now we're adding on pectineus and gracilis. Okay, so you can see the longus as well. There we go. There's pectineus there. So you can see how where it starts from is on that superior pubic rami. So the superior pubic branch, basically, whereas the other ones were on the inferior. So they were tucked down here. So in terms of discomfort, like if there was a tendinopathic issue, then there may be sensitivity there. But again, they do all kind of merge together. So it's difficult to hang your hat on that as a definite. But yeah, this is really, really close to the hip joint. Okay, so pectineus is really close in there. Probably one of the reasons why it's likely to get injured, and because it's got two actions as well. And then the other one, gracilis. So there's your attachment there. And then on the pectineal line around the back there. And then there's gracilis. So it kind of stands on its own, that one. And yeah, so it doesn't really merge into anything else. It is literally right the most medial of all your muscles in that region. So there's the attachment. So this is on the inferior pubic rami, and then down into that pes anserine area. So if you remember back to the knee, I'll just go back here, pause that in that place. So that attachment point there is where the Sargent group attaches. So the sartorius, gracilis, and semitendinosus. Okay, so SGT, Sargent, they all attach into there, and there's some bursa in there as well. Okay, so we've got gracilis on the inside, and then pectineus, which was that really, really short one right at the top. Okay, cool. So those are your three ducts pecking grass. Okay, so adductor magnus, adductor brevis, adductor longus, pectineus, and gracilis. Okay, so all of those help to adduct the thigh or the hip, and they gracilis. Yep, well done, very good. Yep, gracilis means slender. Nice, thanks, Martin. That's good, and where you can see it is. Good. Okay, so let's have a look at the anterior thigh, so the front of the leg, and we're going to look at the muscles that are involved mainly in hip flexion. They may be involved in some other stuff because of the attachments, but they will be the other actions will be quite weak. The main action of these will be mainly flexion. Okay, well, apart from this one, so we've got, well, at the hip, I would say, yeah, because this one, because it crosses two joints, it will also extend the knee, and we've had a look at the knee extension part when we did the knee. So we're focusing on the flexion of the hip, okay, and we've got an attachment point on the AIIS, okay, so just underneath the ASIS. So it's quite low down, and if we there's also two attachments. It's not on here actually. Yeah, so it's AIIS, but there's also a branch that comes off. It splits at the top, and it attaches onto the top of the acetabulum. All right, so we'll have a look at that as well. So let's have a look at the rectus femoris. Hopefully this is it. Yep. Cool. Okay, so rectus femoris, and here it is. Okay, this is someone who's probably quite old when they passed away, because these muscles are very thin. So here's your attachments. Look, so there it is there on the AIIS. So AIIS means anterior at the front, inferior below, iliac spine. So that one there, that knobbly bit there, that's the ASIS, so the anterior superior iliac spine, and then just below it is there where rectus femoris attaches there, so anterior inferior. And then there's a little slip of tendon that comes out just above the acetabulum as well. So AIAS, two heads, there we go, so the one there, and then the other one comes across here, so just there. So that is really close to the glute minimus, around glute minimus, where the glute min attaches as well. And then this is the attachment point on the knee. Okay, so we've got quadriceps tendon here, and then the patella will be under there somewhere. So we're obviously interested, let's go back to this bit. So we're interested in this bit at the moment. There we go. So we've got the supraacetabular groove. So supra is superior, so higher. Acetabular is the socket, and then there's a little groove. Okay, so one of the rectus femoris heads goes into that groove, and then this is the AIIS, which we were talking about before. Okay, so that's the other head of the rectus femoris. Cool. So that hopefully makes this bit make sense. So because of its attachment, it will flex the hip, but it will also extend the knee, because it crosses over the knee as well. And if you are going to injure one of your quadricep muscles, it's usually this one. And it's because of the double action. So because it's a hip flexor and a knee extensor, there's obviously a lot of load going through that muscle. And usually you will get injuries around here. So this is where the muscle belly is here, and then the tendon is here. And as it changes from muscle to tendon, that's a weak spot in the muscle, and that's usually where you will see tears, okay? Or down the other end, distally, okay? So you may see them there. Obviously, you can get them in the muscle belly as well, but they're more likely around that. They call it an MTJ, so muscular tendinous junction, okay? So that's your rectus femoris. Then we start getting into the interesting stuff, okay? So psoas. Sometimes called iliopsoas, but it's probably incorrect to call it that, because the ilio part is the iliacus, and then the psoas part is the psoas, and they are two distinctly different muscles, although they do have a shared attachment distally. Okay, so they do merge together. So that's probably why they're kind of lumped together. But we've got the psoas, which attaches onto the lumbar spine, and the iliacus attaches onto the pelvis. So they're very different anchorage points. They're very different looking as well. So the psoas is very thin, but really, well, I say thin. It's thinner. It's not like fanned out. It's well, basically, it's fillet steak. Okay, so apologies if you're vegetarian or vegan, but it basically psoas is fillet steak. So it's that kind of circular shape, okay, whereas iliacus is a lot flatter, a lot broader, fans out and then comes to a point. Okay, so yeah, very different shapes to the muscles. So we've got hip flexion, which is one of its main functions, but if you have a look at its attachment, it attaches right around the back of the femur onto the lesser trochanter. And because of that attachment and the it goes past the axis of rotation, when it pulls, it can also rotate your femur laterally. Okay, but it will be very weak at doing that. Its main what you call it? Yeah, its main function is for hip flexion. Cool. So let's have a look at that, because this is a really good one. So if ever you have, if you're from a manual therapy background, you probably will have heard this, even from a fitness background, really. I saw something the other day advertised, and it was a thing that you lie on to release your psoas. It was like a two-pronged plastic thing. It looked horrendous. Well, let's have a look, see what you think. You can make your own mind up. Know that those of you that have done this before know my thoughts on this. Okay, so this is the region that we're looking at. So there's your hip joint. This is going up into the lumbar spine a little bit now as well. And there you go. So there's your attachments. So lumbar spine is just here. So that's covered in connective tissue. So we've got the anterior longitudinal ligament. That's the problem with this. Yeah, talking about food all the time. So these are the attachments here, and if you have a look, it goes from L1 to L4 of the vertebral bodies, and then it comes down around here. And the thing that's missing over the top here is the inguinal ligament, and we talked about that a few weeks ago. So psoas comes down here, flicks over that superior ramus. Okay, so it doesn't attach to it, it just goes over it, and then it keeps on going and attaches onto the lesser trochanter. So let's follow it down. So there's your psoas. You can see it there. So there's all your attachments. attaches into the discs as well, and the transverse processes, and we haven't covered those yet, so we'll go over those again when we look at the trunk muscles. Oh, that's really annoying. It didn't do the thingy bit. Never mind. Let's see if I can get a picture of that. Yeah. So this is probably the best image actually that you're going to get. So that along there and then across that superior ramus, and then attaches onto the lesser trochanter just there. Okay. So because of that attachment point where it goes round, if it contracts, it's going to rotate. Obviously, because of the line of the muscle. If it was going to purely rotate, then it would have to come across this way. Yeah. So it's a straight line pull. But because it's coming down and then twisting, that's why it's quite weak at that rotation. Cool. Okay, so that's your psoas. And if we go, in fact, let's go back to that one. Let's go back to about midway here. Cool. So there's your psoas. Now imagine what's in front of all that. So you've got your small intestine, you've got your large intestine, you've also got your obliques, transverse abdominis muscles, so internal and external oblique, plus your rectus abdominis over the top, then fat on both sides, so visceral fat and subcutaneous fat, then your skin, and people are saying that they can palpate psoas. It's going to be impossible. Okay, you will have, see, this is the thing. I think we do a treatment on an area, or we do an exercise for an area, and we get an outcome. So for example, if I shove my fingers into your belly thinking that I'm on psoas, and measure your Thomas test before, so the amount of hip extension you've got, and then it improves, and you're like, oh, okay, cool. So if it's improved, I must have done something to psoas. No, all you've done is improve hip extension. So the outcome is an improvement in hip extension. The mechanism of that outcome is, who knows? Okay, so it can be to do with the hip joint, it could be to do with the anterior musculature, it could be the nervous system. There are so many different things. Okay, yeah, and again, if you're stretching it, if you're stretching that region, you are not just stretching psoas. Okay, so it's the outcome is an improvement in hip extension. So it's similar to the deep gluteal syndrome stuff we were talking about, and the greater trochanteric pain syndrome. We can't pinpoint it to a muscle, so we've given it a broader term, which is better, I think. So for example, if you're doing a hip flexor stretch, I think that's a good term, because you are stretching the hip, the anterior musculature of the and connective tissue and the hip joint of the anterior thigh, but it's not a psoas stretch, yeah, because you can't isolate that muscle. It's impossible to do that. Yeah, I had a client tell me that their chiro told them to get you to release their psoas. Oh, yeah. So it's basically what the message should have been, I think. Correct me if you think something else, but I would like you to have a go at improving the extension of their hip. That would be better. Okay, that would be a better way of putting it, I think. Cool. So yeah, we have this debate every time psoas comes up. So I mean, hopefully it's nothing new to you. If it is, and it's a bit like, I wasn't told that, then just have a bit of a think about it, and whether you think what you've been told is plausible. And then here's iliacus. So we'll finish on this one. So we've got iliacus here. So filling the inside of your iliac fossa. Okay, so the kind of there's a shallow, like a dip, on the inside of the iliac crest, and then there's a conjoined tendon with the psoas, so they join together. This is where I think this might be the video where it goes into lesser trochanter, and then that knobbly bit there is your lesser trochanter. So that's the greater, and that's the lesser, and the lesser's tucked behind. Okay, see, for me, that's the best thing for helping to improve hip extension. Yeah, you do a split squat. Rear foot elevated if they can. It's, yeah, I think that's one of the best exercises to open up the hip. Okay, yeah, good shout. Right, let's have a look at iliacus. Here we go. Sometimes people call it iliacus. I don't know. I've always known it as iliacus, but there we go. So there's your psoas from before, and here is iliacus. Really broad. Look at that attachment. It's a really powerful muscle, this one. Really powerful, because your psoas has got a job on the spine as well. And then this is, I mean, look at that. If I just go back, like, how the hell are you supposed to differentiate through palpation through the skin of any of that? You just got no chance at all. You can say it could be this, could be that, could be that. Okay, so this is where it's going, and then it kind of takes a deep dive. Okay, so under the inguinal ligament, so psoas will come this way as well. This was the video I was after. So there's psoas coming through, and then it goes backwards to there. Do that again. There. Okay, so it's coming backwards and then onto that point there. Yeah, so that's why I say it's a weak lateral rotator. Hip flexor, definitely, and iliacus and psoas joined together, so that's why it's sometimes called iliopsoas. Yeah, that's the attachment point just down there. Yeah, that's what I saw the other day, a 2-pronged plastic psoas poker. Yeah. Yeah, it's yeah, great business. Cool. So that's where we are so far. Cool. Right, just pop that there and that there. So yeah, that's us done for another Monday. Back to Mondays, thankfully. So if you don't know, the reason why I couldn't do last week is I was on a course. I was doing an advanced motivational interviewing course with a chap called Stephen Rolnick, who basically writes the books on MI. And we are taking over, Daniel Williams and me, the motivational interviewing course from Gary Mendoza. So if you've heard of Gary and you've done his course, then his work is being continued through us. If you haven't and you want to do some work on communication, then yeah, feel free to have a look. We'll be doing some advertising for the next course coming up. And yeah, it's there's that, and also I'm in the midst of opening up a brand new training academy dedicated to training for therapists, basically. And it's yeah, so a physical building which is purely that and nothing else, and it's in Ludlow in Shropshire. So if you fancy a weekend away, then yeah, I'm trying to make sure that the courses are on a Friday, so then you can tag on Saturday and Sunday and then stay for the weekend as well. But it's a lovely part of the world, and yeah, it's a little bit less hectic than Birmingham, where I was before. But yeah, listen out for that, because it's nearly done. I was painting yesterday. In fact, there might still be some paint in my hair. Yeah, so that's nearly done too. So that's why there might be some kind of rejigging of things over the next couple of weeks. Yeah, so you'll see it all freshly painted, Claire, in the next in a couple of Thursdays time. So yeah, I will see you all next Monday. We've got a couple of bank holidays coming up, so there will be a bit of a break here and there, just naturally with the holidays. But otherwise, we'll finish off the rest of the musculature, and then we'll have a look at tendinopathies as well, as one of the key things. So we'll go into GTPS and so greater trochanteric pain syndrome and deep gluteal syndrome as well. Okay, cool. Guys, have a good week. I'll see you next Monday.